Hello, thank you for having me. And it's a pleasure to give this talk in updates in the management of non-small cell lung cancer, specifically with the perspective of systemic therapy updates in the last year. I'm Wade Iams. I'm in thoracic medical oncology and the director of thoracic clinical trials at Vanderbilt. These are my disclosures. Relevant to the updated data is Bristol Myers Squibb, manufacturer of nivolumab, that I'll talk about in the neoadjuvant context, but none of the others are related to the updates I'll discuss today. So the talk overview, I want to frame the year in review for systemic therapy for patients with non-small cell lung cancer. And I like to do this in a fundamental fashion, just going by the big categories of disease states by different treatment types. So the talk is broken down first with a focus on resectable non-small cell lung cancer. Then I'll just briefly touch on unresectable non-small cell lung cancer, not stage 4, so anything less than stage 4, where there are no significant updates. By significant, I mean no new FDA approvals to review. And then we'll touch on patients with metastatic non-small cell lung cancer. No new FDA approvals in the first line setting, but we do have an important new approval in the second line setting for patients with metastatic non-small cell lung cancer, and that's trastuzumab deruxtecan. In small cell lung cancer, there's been no new FDA approvals, so we'll just hone in on these key updates in systemic therapy in the resectable or neoadjuvant preoperative setting, and then we'll go through the data that supported FDA approval of trastuzumab deruxtecan for patients in the second line or later. So first, resectable non-small cell lung cancer, defined as patients with stage 1, 2, up to 3A disease. Historically, we've considered neoadjuvant systemic therapy until the recent FDA approval of immune therapy. This was just typically platinum doublet chemo with or without radiation, followed by surgical resection, and then a consideration of adjuvant or postoperative chemotherapy for high-risk features, adjuvant radiation if there were positive margins at surgery, and we're now also considering adjuvant osimertinib for patients with canonical EGFR mutations, or adjuvant atezolizumab if the PD-L1 is 1% or greater. Very importantly, in the last year, we have FDA approval of the neoadjuvant or preoperative use of nivolumab in combination with platinum doublet chemotherapy. And what I would emphasize foremost of all of this is, as of this moment, it is very unclear how this impacts adjuvant atezolizumab. So we already have FDA approval of adjuvant atezolizumab or immune therapy, and now we have approval of neoadjuvant nivolumab with platinum doublet for 3 cycles before surgery. We really don't know how those two are going to relate, and so it's a huge area of ongoing investigation and need. So with that, I'm going to dive into the data that led to approval of neoadjuvant nivolumab plus platinum doublet in patients with resectable non-small cell lung cancer. The clinical trial was called CheckMate 816. It was a big study, randomized with 358 total patients, 179 in each group, who received either platinum doublet with placebo or platinum doublet with nivolumab. And that was for 3 cycles headed into surgery. 3/4 of the patients received cisplatin-based therapy, and then the other quarter it was carboplatin. About 2/3 of the patients had stage 3A disease, 1/3 had earlier stage disease, and it was a 50-50 split of squamous and non-squamous histology. Importantly, thinking about the introduction of immune therapy for these patients, half of the patients had a tumor PD-L1 or TPS score of less than 1%. 25%, the TPS was 1 to 49, and then 25%, it was 50% or greater. And patients with EGFR and ALK patients were excluded from the study, so we should, in practice, evaluate for EGFR and ALK mutations before instituting this therapy. And patients were treated with 3 cycles, followed by surgical resection. The headline clinical outcome was pathologic complete response rate, or the frequency that at the time of surgical resection, no residual cancer was observed. And we see that in the patients treated with nivolumab plus chemotherapy, there was a dramatically higher rate of pathologic complete response than in patients treated with the chemotherapy alone. Most importantly, and hopefully we're all asking, what does this mean for patient survival, which does remain the gold standard endpoint for improvements in practice? And we see promising but early overall survival curves from CheckMate 816. Most impressively, I would call out the 2-year or 24-month time point that has been published from this trial, showing a notable absolute difference in overall survival at 2 years in the nivolumab plus chemotherapy group of nearly 83% compared to 70% in the patients treated with chemotherapy alone. So it does appear that as this data matures, and I would note the survival data remains immature, but it appears that it is going to result in an improvement in overall survival among these patients. And that has caused great enthusiasm, including from myself, about using this treatment for patients with resectable non-small cell lung cancer, particularly those with stage 3A disease, which was a majority of patients in this study. When we think about side effects of this therapy, it's most important to hone in on the impact on surgery. We can imagine in tumor board discussions and discussions with patients, we may tell them they have a resectable cancer, but we want to administer 3 cycles of platinum doublet plus nivolumab prior to surgery. That's going to result in anxiety over the ability or the possibility of postponing or canceling surgery. So because I think all in the audience have administered platinum doublet plus immune therapy, I actually didn't call out the toxicities of that regimen. That is expected and along the lines of as we administer for stage 4, it's systemic doses of the platinum doublet plus immune therapy. We're familiar with that. And when we look at the overall toxicities, there are some degree of fatigue, GI, and dermatologic effects for nearly half of the patients. But when we hone in on how was surgery impacted, surgery-related complications were very analogous in both groups of patients. So any surgery-related complication was about 10 to 15% of patients, both those who received nivolumab and those who didn't. Delays in surgery only occurred about 3 to 5% of the time, and cancellation of surgery only occurred 1% of the time in both groups. Now, importantly, we have to factor in patient selection and that patients on clinical trials are on average more fit with less comorbidities than what we're going to see in the clinic broadly as we roll this out. So keep that in mind, but these are important numbers to know when we're counseling patients that on the trial, it was highly unusual for this treatment to interfere or result in surgery cancellation. So based on this CheckMate 816 data, we had FDA approval of neoadjuvant chemoimmunotherapy in March of this year. And importantly, it's defined as resectable non-small cell lung cancer in the neoadjuvant setting. With that, I'll move on to just a brief refresher on unresectable non-small cell lung cancer, and that from the systemic therapy standpoint, there are no significant updates. If a patient has unresectable stage 1 disease, we're typically administering radiation therapy, most often in the form of SBRT. And if it's stage 2 or 3 unresectable disease, we typically administer concurrent chemoradiation followed by adjuvant durvalumab. In patients with metastatic non-small cell lung cancer, we're typically approaching with our standard paradigm that I'll display on the next slide. And importantly, the approval of trastuzumab deruxtecan for patients with HER2 mutant non-small cell lung cancer is only in the 2nd line or later. So just as a brief refresher, this is kind of a textbook approach to a patient with stage 4 non-small cell lung cancer. In the 1st line setting, we want to obtain that tumor PD-L1 or TPS result, as well as the DNA next generation sequencing for targetable mutations. If a patient has urgent symptoms such as difficulty breathing or approaching an airway obstruction, we can administer 1 cycle of platinum doublet, which is typically the interval it takes to get that DNA next generation sequencing or NGS result, as well as the PD-L1 result. If there's no urgent symptoms, we can wait until we get the biomarkers. treat the patient with an oral option if that is available. If a patient's TPS score is 50% or greater, as long as they're asymptomatic, we'll typically go with immune checkpoint inhibitor monotherapy. And remember that if PD-L1 is less than 50%, it'll typically be platinum doublet plus immune therapy, or we do have the immune therapy doublet of Nivo/Ipi as an option. And remember the molecular distribution of non-small cell lung cancer. This is an older slide, but it's actually, in terms of FDA approval, worked out perfectly for the trend in treatment for patients with non-small cell lung cancer. And in red are the targetable oncogenic mutations in the first line. So EGFR, ALK, RET, BRAF, ROS1, and TRK and MET. We have FDA approved options to treat if we identify those in the first line setting. And this is just a slide to reiterate that there are multiple treatment options in the first line setting for patients with these oncogenic mutations. Moving on to the second line setting where we have another important data update, and I'll dive into some clinical trial data from the Destiny Lung study, is that we had FDA approval of trastuzumab deruxtecan, which is an IV antibody drug conjugate for patients with HER2 mutations very recently. So let's get into the data there. In the second line metastatic non-small cell setting, also remember that we have sotorasib FDA approved in the second line or later for patients with KRAS G12C mutations. And we have both amivantamab and mobocertinib approved for patients with EGFR exon 20 insertions. So not our canonical EGFR exon 19 deletion or L858R, which occurs in exon 21, but an exon 20 insertion, a unique effect on the cancer cells and a unique treatment in the second line or later. Now, in patients with HER2 activating mutations, not immunohistochemistry staining, so it's a little bit different than the typical use in patients with breast cancer, where we're looking at immunohistochemistry or IHC staining. Here, we're looking for DNA NGS activating mutations for the use of trastuzumab deruxtecan in patients with non-small cell lung cancer. And when we circle back to the molecular distribution of non-small cell lung cancer, here in red are the mutations that we have second line or later systemic therapy options. KRAS G12C occurs in about 13% of all patients with non-small cell lung cancer. EGFR exon 20 insertions occur in about 2% of patients with non-small cell lung cancer. Again, that's specifically the exon 20 insertion, much more uncommon than our other mutations in EGFR for which we use osimertinib. And then these HER2 mutations I'm describing occur in about 2% of patients with non-small cell lung cancer. All of this predominantly, but not entirely exclusively, in patients with adenocarcinoma. So the mutations that were included in the study are listed here. And the point of this display is not by any means to memorize the extent of HER2 mutations that were included, but to note that these are DNA next generation sequencing identified results rather than immunohistochemistry results. And I think we're all going to see different vendors identifying these HER2 mutations. Most vendors hopefully are going to keep up with that software to note the FDA approved agents for the mutations as they're identified. But what I want you to take away from this slide is that it's actually a variety of different activating HER2 mutations that underpin the use of trastuzumab deruxtecan in patients with non-small cell lung cancer. And again, this is an antibody drug conjugate administered intravenously every 3 weeks. So let's look at the trial data. This is the Destiny Lung data. This is the data from the New England Journal study that led to initial FDA approval. And I'll tell you about a recent hot off the press update from Destiny Lung 02, just presented within the last week. But in the initial data set that I'll display, it was 91 patients with non-small cell lung cancer treated actually in the median third line or later for the initial Destiny Lung study. 57% of patients were never smokers. So I always point out that over 2/3 of patients had a smoking history. I definitely advocate strongly that patients, regardless of smoking history, have DNA NGS completed because we can find these therapeutic options for those patients. The response rate was a bit over 50%. The median duration of response when it occurred was 9 months, median progression-free survival of 8 months, and I think the median overall survival, particularly when we factor in the third line or later as a median of 17 months, was quite impressive. The most common adverse events were neutropenia. This is grade 3 or greater. And most importantly, when we think about the toxicity of this drug, is drug-related interstitial lung disease. It was lethal in 2 patients in grade 3 or greater in 26% of patients. And so the Destiny Lung 2 study attempted use of a lower dose of the study drug, which is now FDA approved. So in the initial Destiny Lung study, dosing was 6.4 milligrams per kilogram. Recent data just presented from Destiny Lung 2 reported a notable reduction in the frequency of interstitial lung disease down to less than 10%, with a dose reduction to 5.4 milligrams per kilogram. So keep in mind, I think the field will trend and move towards that lower dose, which had a very similar anti-tumor efficacy. So reducing toxicity by dose reduction of trastuzumab deruxtecan is a critical component of implementation. And when we look at the anti-tumor effects in visual form, we see this is a waterfall plot, which captures the typical shrinkage in the tumor. So the percentage change from baseline tumor measurements, where everything below 0 is some degree of reduction in the tumor size. So really outstanding results in tumor shrinkage from the use of trastuzumab deruxtecan for these patients. And I would call out, it's a pretty packed slide with information, but at the bottom here, the HER2 immunohistochemistry expression was variable, and we still saw good effects of trastuzumab deruxtecan even when the expression was 0, as long as they had that activating HER2 mutation. So our top row here is that all patients had presence of one of those long list of HER2 activating mutations, and it is not determined by the HER2 expression. And we saw outstanding results in tumor reduction among these patients with activating HER2 mutations. The overall survival curve, what I would call out is, it is single arm, which led to approval. So we don't have a comparator group for this patient population, but recall that this was third line or later median for these patients, and nearly 18 months as a median overall survival is impressive for this patient population. So this led to FDA approval. It is accelerated approval just in August of this year for patients with unresectable or metastatic non-small cell lung cancer with an activating HER2 mutation who have received a prior systemic therapy. So any prior, but it must be second line or later for the current use. In sum, we now have NCCN supported and FDA approved treatment options for more and more of our pie of potentially targetable mutations in patients with non-small cell lung cancer. And we're, as a field, hoping to continue to chip away at that and thereby continue to improve outcomes for our patients. That's it. And in sum, I want to recap that the 2 major updates for the year in review are the FDA approval of neoadjuvant platinum doublet plus nivolumab, as well as the FDA approval of trastuzumab deruxtecan in the second line or later for patients with activating HER2 mutations. Unfortunately, no major updates in patients with small cell lung cancer, although we're hard at work trying to improve outcomes for those patients, and it remains a huge need. Thank you for your attention.